Welcome to the deep dive. We are embarking on a really crucial exploration today, focusing entirely on the systems that allow us to move, the musculoskeletal structures.
That's right.
We're diving into Porth's Pathophysiology, chapter 48 specifically, to try and get a quick but still thorough understanding of how things like trauma, infection, ischemia, and neoplasms can alter health in our bones, joints, and soft tissues.
It's definitely an important deep dive.
Yeah.
The musculoskeletal system, it's this intricate frame, right? 206 bones in adults, joints, muscles, tendons. It's constantly facing stressors, both outside and inside. So our mission today really is to get beyond just describing injuries. We want to focus on the mechanisms. Why do these things happen? Why do they lead to the pain and disability and sometimes, really life-threatening issues we see clinically?
That sets the stage perfectly. So we'll unpack the immediate effects of trauma, everything from a simple bruise up to like major complex fractures.
Right.
Then we'll track how things heal, look at the unique problems infections cause in bone, and finally touch on bone tumors. Let's jump right in with trauma's impact.
Okay. Well, the statistics themselves are pretty stark. They really remind you of the forces involved. In the U.S., injury is still the #1 cause of death for people aged 1 all the way up to 44.
Wow, 1 to 44.
Yeah, and motor vehicle crashes, they dominate for the younger group, that 1 to 30 age bracket.
But it shifts for non-fatal injuries, doesn't it?
It does. When you look at injuries that don't cause death, falls suddenly become the main culprit. They're the most common cause for both kids and, importantly, for older adults, say 65 plus.
And that's where underlying health really comes into play, especially for older people.
Exactly. A fall might be the trigger, the event itself. But the source material points out that often osteoporosis is already there. The bone is already weakened before the fall.
So the fall happens to an already compromised structure.
Precisely. And that combination, the weak bone plus the fall injury, especially a hip fracture, leads to some frightening numbers. Mortality after a hip fracture can be anywhere from like 18% up to 33%.
That high. Is that mostly from the surgery itself, or what happens afterwards?
It's mostly the complications afterwards. It's the long time being immobile, the risk of pneumonia, blood clots, just general deconditioning. The hip fracture often just kicks off this cascade in someone who might already be vulnerable.
Okay, let's zoom in a bit down to the tissue level, starting with soft tissue. Contusion, that's blunt trauma. Skin stays intact, right?
Yeah, think of that classic black and blue mark the ecchymosis. What you're actually seeing is the body slowly reabsorbing that trapped blood. The source describes it visually starts black or blue, fades to brown, then eventually yellow as the blood pigments break down.
And if there's more significant bleeding?
Then you get a hematoma. That's a larger collection of blood. It causes pain, mainly because it builds up pressure on the nearby nerve endings.
So for both, the immediate goal is reducing that swelling. Elevation, cold packs.
Generally, yes. Elevation, cold application helps limit the initial swelling and bleeding.
Okay, but what if the skin is broken? A deep cut, a laceration, or maybe a puncture wound? That changes things drastically.
Completely different ballgame. Contamination becomes the immediate, urgent concern. Puncture wounds are especially tricky
Why is that?
because they often push bacteria deep into the tissue, and then the entry point can kind of seal over. That creates an anaerobic environment, low oxygen.
Ah, and certain bacteria love that.
Exactly.
Yeah.
That low oxygen setting is perfect for nasty bacteria that cause tetanus and gas gangrene. That's why any contaminated wound, and definitely an open or compound fracture where bone is exposed, needs immediate, really thorough cleaning debridement. Sometimes surgeons even leave the wound open initially to prevent that anaerobic infection from setting in.
Okay, so we've covered skin mimics and muscle damage. What about forces focused purely on the joint structures? We often mix up strains and sprains.
Yeah, it's common. A strain affects the muscle itself, or the unit where muscle connects to tendon, the musculotendinous unit. Think of pulling a muscle in your lower back or neck.
But there's a specific warning in the text about back pain in young athletes, isn't there?
Yes, a clinical caution. If an adolescent athlete has persistent mechanical low back pain, especially in sports with lots of hyperextension like gymnastics or diving, you can't just assume it's a simple strain.
You have to think about something more serious.
You have to worry about potential stress fractures in the vertebrae. That's called spondylosis, or even one vertebra slipping forward on another, which is spondylolisthesis. Needs investigation.
Got it. And sprains then involve?
Sprains involve the ligaments, those tough bands that stabilize the joint. They happen when the joint moves abnormally or excessively.
And there are different grades of severity.
Right. The source describes a range. Grade 1 is just a mild tear. It goes all the way up to grade 4, which is a complete tear of the ligament. Sometimes it even pulls a piece of bone off where it attaches. That's an avulsion fracture.
Common spots are ankles, knees. The ACL is a famous one.
Definitely. Ankle sprains and ACL tears are very common examples.
How well do these heal?
Healing is, well, it's to process. Fibroblasts have to come in and lay down collagen to rebuild that structure. It takes a while, maybe 2 months, to get back full tensile strength.
And there are risks during that time.
Yes, there's a risk it could heal in a stretched out, weakened position, or, especially in complex areas like the hand, you can get excessive scar tissue forming adhesions, which really restrict movement later on.
What if the force is enough to actually pop the bones out of alignment in the joint?
Then you have a dislocation, which is a complete separation of the bone ends, or a subluxation, which is only a partial separation. We see these a lot in shoulders, also the AC joint where the collarbone meets the shoulder blade.
And they tend to happen again.
That's the problem, especially in young, active people. There's a high risk of recurrence once a joint has been dislocated.
You also mentioned loose bodies. What are those?
They're basically small fragments, could be bone, could be cartilage, just floating around inside a joint space. Often happens from wear and tear or previous injuries.
Are they just annoying or do they cause bigger problems?
They can be more than annoying. They can cause the joint to catch or lock up suddenly. And importantly, having them there significantly bumps up the risk of developing serious osteoarthritis in that joint later in life.
Okay, let's shift to fractures now. Actual breaks in the bone structure. How are they classified?
Logically, yeah. First, by cause. Was it a sudden injury, like from a direct blow or fall?
Okay.
Or was it a fatigue or stress fracture? That's from repeated wear and tear, like you see in runners. These can be tricky because they sometimes get dismissed as shin splints early on before they actually show up on an x-ray.
Right. And the third cause?
Pathologic fractures. This is where the bone breaks because it was already weakened by some underlying disease, like a tumor or severe osteoporosis. It might break with minimal or no trauma.
And then we classify them based on whether the skin is broken.
Exactly. Closed fracture means the skin is intact over the break. Open or compound fracture means the bone has pierced through the skin.
And the text really flags open fractures as higher risk.
Absolutely. There's a concept mastery alert about this. That break in the skin dramatically increases the chances of complications. Infection is a big one. Also problems with healing, like non-union.
We also describe the fracture pattern, right? Like how the bone broke.
Yes. Transverse is straight across. Spiral suggests a twisting force. Comminuted means the bone is broken into more than 2 pieces, shattered, essentially. There are others too, like compression fractures in vertebrae or green stick fractures in kids where the bone bends and cracks but doesn't break all the way through.
And you mentioned muscle pull can complicate things.
Definitely. With major long bone fractures, the strong muscles around the bone can spasm powerfully, pulling the broken ends so they overlap. This causes shortening of the limb.
That sounds painful.
It is. And another major risk with severe fractures, especially multiple long bones or the pelvis, is massive internal bleeding. That can quickly lead to hypovolemic shock. It's a true emergency.
So when treating a fracture, what are the main goals?
There are 3 core objectives. 1, reduction, getting the bones back into proper alignment. 2, immobilization, keeping them stable so they can heal. And 3, restoration of function, getting the person moving again safely.
How is reduction done?
It can be closed, meaning manipulating the bones back into place from the outside without surgery, or it can be open, which requires surgery. That's where they do an open reduction and internal fixation, or ORIF, using plates, screws, rods, pins inside the body to hold the bone together.
And immobilization usually means casts, splints.
Yes, casts and splints are the most common methods, but you have to be careful with casts.
Because of swelling.
Exactly. If swelling occurs inside that rigid cast, the pressure can build up and cut off circulation to the limb distal to the cast.
What are the warning signs?
You look for cold or bluish fingers or toes, skin taking a long time to turn pink again after you press it. That's prolonged capillary refill. And critically, any neurological changes, numbness, tingling, pins and needles, what we call paresthesias.
And if you see those signs?
That cast needs to be split or taken off immediately to restore blood flow. It's urgent.
What about traction? Is that still used?
It is. Traction uses weights and pulleys to gently pull on the limb. The goals are to help align the fracture, reduce pressure on the fragments, and decrease painful muscle spasms. It can be skin traction, applied to the skin, or skeletal traction, where pins are put directly into the bone, often used for femur or humerus fractures.
The text also mentions a specific type of external fixator, the Elizarov.
Ah, yes, the Elizarov device. That's quite fascinating. It's an external frame, usually circular, attached to the bone with wires or pins. It stabilizes the fracture, but its unique feature, really an aha moment, is its ability to lengthen bones.
How does it do that?
Through a process called distraction osteogenesis, you slowly, mechanically pull the bone ends apart, just a tiny bit each day. This stimulates the body to generate new bone in the gap. But remarkably, it also encourages regeneration of the surrounding soft tissues, nerves, and blood vessels too. It really harnesses the body's own regenerative potential.
Incredible. Let's talk about the actual bone healing process. It happens in stages.
Yes, four main stages. First is hematoma formation. When the bone breaks, blood vessels tear and bleeding occurs. This forms a clot, hematoma, which provides the initial framework, kind of like biological scaffolding.
Okay, stage 1, clot.
Stage 2 is the inflammatory phase. Within days, blood vessels start growing into the hematoma. That's neovascularization. Inflammatory cells arrive, and fibroblasts, the cells that make collagen, start migrating in. Early fibrous tissue starts forming.
Stage 3.
The reparative phase. This is where the real rebuilding happens. First, fibroblasts and chondroblasts form a fibrocartilaginous soft callus that bridges the fracture gap. Then, over the next few weeks, osteoblasts replace this with woven bone, forming a hard, bony calluses. You can usually see this on X-ray around 3-4 weeks after the injury.
And the final stage.
Remodeling. This takes months, even years. The bony callus is gradually reshaped. Osteoclasts, the bone-resorbing cells, remove dead bone and excess callus. Osteoblasts lay down organized, compact bone along lines of mechanical stress. The bone eventually returns to something close to its original shape and strength.
But sometimes healing doesn't go smoothly. What can go wrong?
Several things. Malunion means the fracture heals, but in a deformed or incorrect position. Delayed union means it takes significantly longer to heal than expected for that type of fracture. And non-union means it fails to heal completely, leaving a persistent gap or instability. Open fractures, especially of the tibia, are notorious for non-union because the blood supply can be so disrupted.
And besides healing problems, there are other major complications we need to watch for.
Absolutely. Two really critical ones are compartment syndrome and fat embolism syndrome.
Let's start with compartment syndrome. What is that exactly?
It's a condition of increased pressure within a confined anatomical space, usually a muscle compartment, bounded by tough, inelastic fascia. Think of the muscles in the lower leg, for instance.
What causes the pressure increase?
It can be one of two things. Either the compartment size decreases, for example, from a cast that's too tight or constrictive dressings, or, more commonly, the volume inside the compartment increases, usually from bleeding or severe swelling, often after a fracture or crush injury.
And why is that pressure dangerous?
Because as the pressure rises, it exceeds the pressure in the capillaries. Blood flow to the muscles and nerves within that compartment gets cut off. Tissue starts to die from lack of oxygen, ischemia, and necrosis.
What's the key symptom to watch for?
The hallmark symptom is severe pain, pain that seems way out of proportion to the original injury. It often doesn't get better, even with strong pain medication.
Are there other signs?
Yes, neurological changes are crucial paresthesias, like numbness or tingling, and later, maybe weakness or paralysis of the muscles in that compartment. Interestingly, the main peripheral pulses might still feel normal early on because the pressure might not yet be high enough to block the larger arteries. That can be misleading.
So you can't rely on just checking pulses. What's the treatment?
It's an emergency. If a cast is involved, it needs to be split or removed immediately. If that doesn't work, or if there's no cast, the definitive treatment is a surgical procedure called a fasciotomy. They make long incisions through the skin and fascia to open up the compartment and relieve the pressure before permanent damage occurs.
Okay, that sounds critical. What about the other one, fat embolism syndrome? FES.
FES is another potentially lethal complication. It happens typically after fractures of long bones like the femur or the pelvis.
What's the mechanism?
The idea is that fat globules are released from the bone marrow at the fracture site. These fat droplets enter the bloodstream through torn veins.
And they act like clots.
Exactly. They travel through the circulation and lodge in small blood vessels, primarily in the lungs, but also the brain and skin capillaries. This causes inflammation and obstructs blood flow.
What are the symptoms?
The classic triad usually appears about 12 to 72 hours after the injury. It includes 1. respiratory failure, shortness of breath, low oxygen levels. 2, cerebral dysfunction, confusion, changes in consciousness, seizures. And 3, a petechial rash, tiny red or purple spots, often on the chest, axillae, and conjunctiva.
Also sounds very serious.
It absolutely is. Requires intensive care support.
All right, let's shift gears now to bone infections, osteomyelitis.
Osteomyelitis is an infection of the bone tissue and the bone marrow. It can get started in a couple of ways.
Okay.
Most commonly in the U.S., it's through direct penetration. This means bacteria get in directly from the outside, like from an open fracture, a penetrating wound, or even during surgery.
Makes sense. The other way.
Is hematogenous spread. This means the bacteria travel through the bloodstream from an infection somewhere else in the body and then settle in the bone. This route is more common in children, affecting their long bones, and in adults, it often hits the vertebrae or joints.
Is there a usual suspect, bacterium-wise?
Staphylococcus aureus is the most frequent culprit by far.
Why is osteomyelitis so hard to treat, especially when it becomes chronic?
The pathophysiology explains it well. When bacteria cause infection in bone, pus purulent exudate collects. Because bone is rigid, the pressure builds up quickly. This high pressure can actually compress and shear off the small blood vessels supplying the bone cortex.
So the bone tissue itself dies from lack of blood.
Precisely. This piece of dead infected bone is called a sequestrum. Now, the body tries to wall off this dead infected area by forming a layer of new bone around it. This sheath of new bone is called the involucrum.
So you have dead infected bone trapped inside a wall of new bone.
Exactly. The sequestrum is a vascular, no blood supply, so antibiotics delivered through the bloodstream can't reach the bacteria inside it effectively. And the involucrum kind of shields it. This presence of sequestrum and involucrum is the defining feature of chronic osteomyelitis, typically defined as infection lasting longer than 6 to 8 weeks. It often requires surgery to remove the dead bone.
We should also mention tuberculosis of the bone, right? Pot disease.
Yes, definitely. TB can spread, usually hematogenously, to the bones and joints. It causes extensive necrosis, really destructive lesions. It has a particular liking for the spine, the vertebrae, and intervertebral discs. That's pot disease. The big danger there is collapse of the vertebrae, leading to spinal deformity and potentially severe neurological damage, even paralysis.
Okay, moving from infection to lack of blood supply for other reasons, osteonecrosis.
Osteonecrosis, also called a vascular necrosis or AVN, is literally bone death due to an interruption of its blood supply, but without an infection being involved.
Why does the blood supply get interrupted?
Certain locations are just more vulnerable because they have a naturally poor or tenuous blood supply with limited collateral circulation. The classic example is the head of the femur, the ball part of the hip joint.
What typically causes it?
Trauma is a big one, a fracture or dislocation that tears the blood vessels supplying that bone segment. Sickle cell disease can cause it due to blocked capillaries. And a very common non-traumatic cause is long-term or high-dose corticosteroid therapy. We don't fully understand the mechanism there, but it's a well-known association.
What happens when that bone segment dies?
The dead bone under the joint cartilage, a subchondral infarct, eventually weakens and collapses under weight-bearing stress. This leads to chronic pain, joint dysfunction, and inevitably severe secondary osteoarthritis.
The treatment often ends up being.
In advanced stages, especially in the hip or knee, total joint replacement is often the only effective option to relieve pain and restore function.
All right, our final major topic, neoplasms or bone tumors. How do we generally categorize them?
The first big split is between benign and malignant. Benign tumors tend to be slow-growing, well-defined, with clear borders on imaging. A good example is osteochondroma. It's actually the most common benign bone tumor. They usually cause problems just by taking up space or impinging on nerves.
And malignant tumors?
They're the opposite. Usually ill-defined borders grow rapidly, destroy surrounding tissue, and sadly carry a high mortality rate. It's important to note that primary malignant bone tumors, sarcomas that start in the bone, are actually quite rare.
But metastatic tumors aren't.
No, metastatic bone disease cancer that started somewhere else and spread to the bone is far, far more common.
What are the typical symptoms that might make someone suspect a bone tumor, benign or malignant?
Pain is the most common symptom. There might be a palpable mass, an impaired function, or joint swelling. But there's a critical differentiating feature often mentioned. Pain that persists at night and isn't relieved by rest should definitely raise suspicion for malignancy. Benign pain often eases with rest.
Let's touch on the main primary malignant bone tumors, the sarcomas.
Okay. The most common primary one is osteosarcoma. It typically affects children and adolescents, often during their growth spurts, and frequently occurs near the ends of long bones, especially around the knee distal femur or proximal tibia.
And its behavior.
Highly aggressive, it tends to metastasize early, most commonly to the lungs via the bloodstream. Treatment usually involves chemotherapy followed by surgery. Limb-sparing surgery is more common now, but amputation is still sometimes necessary.
What about Ewing sarcoma?
Ewing sarcoma primarily affects children and young adults, typically under 20. It often arises in the diaphysis, or shaft, of long bones like the femur or in the pelvis. A key point here is that it can present with systemic symptoms, fever, weight loss, fatigue, which can sometimes mimic infection and delay the correct diagnosis.
Is it treatable?
Yes, it's actually highly sensitive to radiation therapy, in addition to chemo and surgery.
And the third main type?
Chondrosarcoma. This is a sarcoma arising from cartilage cells. It's the most common primary bone sarcoma in adults, usually middle-aged or older. It tends to be slower growing than osteosarcoma or Ewing, often painless initially, but it's notoriously resistant to both chemotherapy and radiation. Surgery is the mainstay of treatment.
But as you said, metastatic disease is much more frequent overall.
Much more. It's estimated that maybe half of all patients with cancer will develop bone metastases at some point.
Where do these metastases usually come from?
The most common primary sites that spread to bone are prostate cancer in men, breast cancer in women, and then lung, kidney, thyroid, and colorectal cancers.
What are the main problems caused by bone mets?
Again, pain is a major issue, often worse at night. And a huge risk is pathological fracture, the weakened bone breaking under normal stress. This is especially common in the spine, femur, and pelvis. Spinal cord compression from vertebral metastases is another serious complication.
So the treatment focus is often palliative?
Yes. For metastatic disease, the goal is usually palliative controlling pain, preventing fractures, maintaining function and quality of life.
How is that done?
Radiation therapy can be very effective for localized pain. And specific medications are used to target the bone destruction process itself. Cancer cells often release factors that stimulate osteoclasts, the bone-resorbing cells, to work overtime, creating osteolytic lesions, basically holes in the bone.
So drugs are used to slow that down?
Exactly. Drugs like bisphosphonates and denosumab work by inhibiting osteoclast activity. They help reduce bone pain, lower the risk of fractures, and can slow the progression of the bone lesions.
Wow, that was a dense tour through a lot of pathology. So to kind of summarize...
Yeah, I mean, the musculoskeletal system structure really dictates how it responds to insults. Trauma sets off that predictable four-stage healing cascade, but the rigid compartments create risks like compartment syndrome.
Right. And infections are tough because the bone's rigidity and vascularity allow that sequestrum involucrum situation to develop, shielding the bacteria.
Exactly. And the neoplasms you really have to differentiate based on growth patterns, borders, and that key symptom of night pain to distinguish benign from malignant. And remember that metastases are way more common than primary bone cancers.
It really highlights how understanding the underlying mechanism, the pathophysiology, links directly to what we see clinically and what we need to do urgently.
Absolutely. Like knowing about the femoral head's vulnerable blood supply tells you why reducing a dislocated hip quickly is so vital. You're trying to prevent that avascular necrosis. The why dictates the what and when of treatment.
So as a final thought for you, our listener, as you reflect on all this, consider the stark contrast in how injury manifests across the lifespan. Think about the difference between, say, a child's green stick fracture, where the young, pliable bone bends and cracks but doesn't fully break, and the devastating, often fatal hip fracture in an elderly person whose bone is already weakened by osteoporosis.
A powerful contrast.
It really is.
Yeah.
And it prompts the question, how must our prevention strategies differ? How do we tailor approaches to address the very different vulnerabilities at each end of the age spectrum, whether it's protecting kids from acute trauma or building bone health to prevent fragility fractures in older adults? Something to think about.
Definitely food for thought.
That's all the time we have for this deep dive into musculoskeletal pathology. Thanks so much for joining us. We'll see you next time.